Um, Thank you, Aldo, for a wonderful and exaggerated introduction. It's a real pleasure for me to be here and to give this first lecture on my friend and colleague, Attilio Mazzari. I think you all know that Professor Mazzari is a leader of world cardiology. He has had enormous impact in Italy, in Europe, in the world. And over the past 50 years, I cannot recall anyone who has matched his contributions. So it's a great pleasure and an honor for me, Attilio, to be here to give this lecture. So I want to say a few words about the accomplishments of Professor Mazzari. You've given me about an hour for this lecture, and I could take up 59 minutes with Attilio's contributions, but I will take up only 9 minutes. And I have neglected all the many papers, excellent papers that he's written and published in Italian journals, because I couldn't understand a word. So I'm concentrating on his major papers in the English language. But please recognize that this is only a minority of his contributions. Well, to many people around the world, he is known as the person who has introduced the concept of dynamic coronary artery lumens. And in this classic paper in The Lancet in 1977, he showed that coronary vasospasm plays a role in angina pectoris, not only in Prinzmetal's angina, but in the regular angina at all. And here's a paper with his colleagues just 2 years later, which I have considered a classic. It shows the sequence of events in angina at rest. So this is angina at rest, and it showed that primary reduction of coronary flow is what sets off the angina. Let me try to see if I can explain this. So this is at a very slow speed of the drum. And here's the electrocardiogram, and here are isolated cardiograms, A, B, and C. And this is coronary sinus oxygen saturation. And this is LVDPDT and left ventricular pressure. So here's this patient, has a coronary sinus oxygen saturation about 45, and then it suddenly goes down. Goes down because obviously there's a reduction in the lumen of the coronary vessel. And as you can see that within a few seconds, the electrocardiogram changes. The T wave, which was downward, is displaced upward. The patient is hypoxemic. The LVDT goes down. Left ventricular systolic pressure falls a little bit, but more importantly, left ventricular diastolic pressure rises. Then the coronary sinus oxygen goes up, so the spasm has been released, and everything returns to normal. So you can see here at C, the electrocardiogram has returned to normal, and the left ventricular diastolic pressure has returned to normal. So I have used this in teaching. I've used this illustration in several textbooks. It's really a very important signal in cardiology. Professor Mazzari has done important work in the early thrombolysis days in 1984. In this paper, in the New England Journal of Medicine, he showed that in patients with threatened myocardial infarction, coronary occlusion may be intermittent, despite the presence of continuous chest pain. And I think he made the important point, since the occlusion comes and goes, just as we saw in this patient with angina, there are 1 or 2 hours available to really, if you come in and treat the patient at that time, to actually prevent myocardial infarction. During his years in London, he made many important studies, and here is one that I want to highlight, and it shows that he has been a master of imaging as well. And here he used positron emission tomography. In 1992, when I visited him in London, he was really at the frontier because PET scanning had not yet been developed, and it showed how you could recognize patients who would or who would not respond to coronary bypass surgery. And then, of course, one of his most enduring contributions is he is the person who really put his finger on the inflammatory theory of coronary disease. And he showed in this paper, very early paper, 1994, elevation of C-reactive protein at the time of hospital admission in patients with angina showed that there would be a poor outcome, and it reflected the important inflammation. This was a new concept, and many people did not believe it, but now it's been studied in detail. And he also published a second classic paper in the New England Journal of Medicine in which he showed that there was widespread inflammation in unstable angina, not only in the vessel, which was the culprit, but he found that, that there was an activation of white blood cells coming out of the other vessels as well. And that signified that there was instability in the entire coronary vascular bed. So it's not only a single lesion, it's the entire bed that's modified. He has had, discussed with me many times, a very interesting theory. And he points out the fact that there are 2 outlier populations that we need to learn much more about coronary artery disease. And in this recent paper published just this year, he has shown that there are extreme outliers. On the one hand, we see patients who have no coronary artery disease despite the fact that they have multiple risk factors. And there are many patients like that. And at the opposite end, there are patients who have diffuse coronary artery disease despite a low risk factor profile. So what is going on here? And I think that is the work that he's pursuing now. And it's extremely important because it shows we are moving into an era, and Professor Masri is leading it, of what we call precision medicine. Instead of everybody being about the same, you have to single out people and who are different from one another, and to develop treatments for various types. So it is because of these and many other contributions that it's a special honor for me to give this lecture. Now, I do want to say that this book is a classic, and I study from it frequently until you authored this single-handedly. This is no longer an era where one person writes books, but if there's one person, it's Professor Masri, and it gives the entire story of ischemic heart disease. And I want to talk to you about heart failure, but I need to drink of water. So I have entitled this The Past, the Present, and the Future. So the past, and the past doesn't go back to the great William Harvey, but it goes back to 1952 when I graduated medical school. And I want to take you back to that time. I don't think anybody in this room other than I have been a physician since 1952. Take you back to this time. So the hypertension, perhaps the most common cause, second most common cause of heart failure, no treatment at all. Acute myocardial infarction, no coronary care units, mortality of the patients who got into the hospital, and most of them never made it to the hospital, 30%. Rheumatic heart disease, what was called senile cardiomyopathy, and leuetics, syphilitic aortic valve disease, were very important causes of heart failure. Idiopathic dilated cardiomyopathy and diastolic heart failure, or what we now call HFpEF, were not recognized at that time. So what kind of treatment did we have? Well, strict bed rest, sedation, inhale oxygen, diet, reduced calories, give vitamins very important, and extreme sodium restriction to 200 to 400 milligrams a day. Now, I think what this sodium restriction did is it did not prolong life, but it made life seem longer. Digitalis, given almost universally. Diuretics, organic mercurials given by painful, deep intramuscular injections. And believe it or not, we also removed blood from the veins and gave rotating tourniquets to patients with pulmonary edema. So that, to me, this is what I saw in congestive heart failure when I graduated medical school. And then things began to change. And in the next few years, still in the 1950s, two very important classes of drugs were developed. And they were developed in industry. The first one, by Merck Sharp and Dohme, are the thiazides, chlorothiazide, benzothiazine dioxide, oral diuretics that were potent, changed the whole ballgame. And then coming out of the Searle company, the pharmacology of a drug that blocks aldosterone. And we know this is a mineralocorticoid receptor antagonist. So obviously, very important agents. One of the things that we didn't have, and I went to work after my training in internal medicine and cardiology. I went to work to do full-time research at the National Heart Institute. And I worked there for 13 years. And I want to show you a couple of things that came out of this period. In 1962, we didn't have, I felt, I was interested in heart failure, but we didn't have a good way of measuring cardiac function. And we developed a technique by injecting radioactive isotope and measuring its washout with a precordial detector of measuring the fraction of the left ventricular volume ejected per beat. This is the first measurement of ejection fraction, and it still is a useful measurement. So that at least allowed us to carry on some studies. Also in 1962, we developed a technique. It was really more an electronic technique to record continuously the first derivative, the dp/dt of ventricular pressure, because the physiologists, Carl Wiggers and others, had taught us that the rapidity of the rise of ventricular pressure is an important characteristic of contractility, and the rapidity of the decline is a measure of relaxation. So here we have a patient in the cath lab. You see the left ventricular pressure is measured with a micromanometer placed on the catheter, and you can see the dp/dt. Here we gave the patient some isoprel, and you can see a marked increase in dp/dt, so a marked increase in the rapidity of contraction, and then no real difference between the negative dp/dt. Then the isoprel is washed out, the patient is given atropine, there's an increase in heart rate, the dp/dt is a little higher than control, and the rapidity of relaxation is greater than control. Well, between these two methods, it was possible to study heart failure in a more meaningful way in patients. We also, in 1962, began to think about the neurohormonal abnormalities. They were not recognized. But the great clinicians of the turn of the 19th to the 20th century, William Osler, professor at Johns Hopkins and professor at Oxford then, in his textbook said that patients with heart failure acted as if they had more sympathetic nervous system activity. They were adrenergic. Now, we had no way of proving that. But we were very lucky at the NIH because it was a huge assemblage of scientists and clinicians. And our laboratory was right next to the laboratory of a famous pharmacologist, Julius Axelrod, who won the Nobel Prize. And his technician taught my technician how to measure for the first time catecholamines norepinephrine. And what we did is we measured norepinephrine concentration first in the blood on the left-hand side, then in the urine on the right-hand side. And you see the normal range is shown in light blue here. And here are patients with heart failure. You see the plasma norepinephrine concentration. Half of them are within normal limits, and the other half are elevated. It's not a big series of patients. And this is with exercise, and these are multiples of resting oxygen consumption. So as we go from here to here, they're exercising more, and you see they all have an elevated norepinephrine. And then on the right-hand side, you see the 24-hour urinary excretion, so it really takes all the cycles that occurred in patients who were normal, patients who were in cardiac class 1 and 2, elevated in 3, and elevated in 4. So this opened the idea that sometimes neurohumoral abnormalities can affect, can be present in congestive heart failure. But congestive heart failure, it may begin with abnormalities of the heart as a pump, but the implications are that there are neurohumoral changes. In the 1980s, this is a big jump in time, a quarter of a century between these two slides. I was working in Boston at Harvard and the Brigham with Janice and Mark Pfeffer, and we studied rats in whom myocardial infarction was produced. And what we observed was that we did really a clinical trial in rats. And the first clinical trial is we looked at rats that had no infarction. And you see there on the left-hand side, panel A, they did very well. They had 90% survival over a year. Pretty good for a rat. Then we gave them moderate-sized infarctions. And if you look at the solid line, water, you see that about 70% died. Only 30% were alive. We also treated them with an ACE inhibitor, captopril, and you see that the majority lived. And so there was a 40% benefit in survival of these rats with moderate-sized infarction. So that set up the renin-angiotensin system as the second system that could go wrong in patients with heart failure. Of course, you saw this slide again. It came from this paper in which we described that after myocardial infarction, there is remodeling of the ventricle. Now, obviously, this is the infarct, and after a couple of weeks, you see it thinning. But what's really important is that the rest of the myocardium has to do the work that this group doesn't do, and therefore the ventricle changes shape and becomes dilated. And that's what you treat with an ACE inhibitor following acute myocardial infarction. And Dr. Pfeffer and I and other colleagues carried out the first trial in post-myocardial infarction. Patients had a reduced ejection fraction under 40%. They were treated either with placebo, double-blind trial, or captopril, and there was a 21% reduction in mortality. Okay, so that's the past. Now some words about the present in heart failure. I will give you some US statistics. The statistics in Europe are very similar, but you have to add another 50% to the numbers because Europe has about 50% greater population than the United States. Okay, we have more than 5.8 million heart failure patients in the United States. There are more than 1 million hospitalizations a year. Heart failure is the most common hospital admission diagnosis in Medicare patients, that is, in patients over the age of 65 years. And there is a demographic imperative because heart failure tends to occur mostly in older people, and aging is increasing. And that's the population in Europe as well as in North America that is increasing most rapidly. And by 2030, which is only 13 years away, it is expected that if nothing changes, unless we do something, there will be 50% more patients in 2030. And I think that this is not good news, and we should look at this not only in a pessimistic way, but as challenges in the field. Here are much more not so good news, more challenges. There has been no improvement in the outcomes of patients with heart failure and preserved ejection fraction. Actually, there has been little improvement in patients with acute heart failure. In our system, the 30-day mortality of patients admitted with acute heart failure is 11%, and the hospital readmission rate in 90 days is 25%. 5-year survival of patients with acute heart failure is worse than it is for most cancers, and the annual cost is greater than $30 billion. So I put this into the category of more challenges also. So this is a blank slide. Why is heart failure such a serious problem? Because we know there are tremendous advances in heart disease. We're very proud in cardiology of what's been accomplished. But we have heart failure, which is getting worse and worse now. How do you line those two up? Very simple. Heart failure is the price that we pay for the successful treatment of heart disease. An example would be, go back to 1952 when I was a student. A 45-year-old man would come in with a STEMI and probably die, because the mortality rate, I told you, was 30%. This man now would be treated very rapidly. As Professor Masri pointed out, if he's treated in the first hour or two, you might even avoid an infarct. But he hasn't been cured of coronary disease. He still has diffuse coronary disease. Again, something that Masri taught us because of the inflammatory nature. So what happens, he gets small infarcts along the way. At the age of 75, he comes in severe heart failure. Take a patient with hypertension. I told you in 1952, we had no treatment for hypertension. Now we have terrific treatment for hypertension. But people are not compliant. If you record blood pressure in treated hypertensives and you take the blood pressure over 7 days, 24 hours a day, you find that they are controlled for 30% of the time. So they still develop hypertensive heart disease, maybe more slowly, but they still develop it, and therefore they go to heart failure. And you can say the same thing about congenital heart disease. In congenital heart disease, where we think we have conquered everything because the surgery is magic. The surgery is magic. In the United States, and I'm sure the case is the same here, there's no reason to be different, we have 1 million patients, adults, who have, in quotation mark, cured congenital heart disease. That means they've had ventricular septals, tetralogies, aortic stenosis, treated brilliantly when they were children, under the age of 10. But what happens? Their average time, duration of life is about 60 years. It's not 78 years as it is for everybody. And they die of heart failure because those ventricles are not normal. So heart failure is the price that we pay. In the past, they would have died in infancy. But this is the price that we pay. Okay, so what are the major treatments that we have? And this slide shows you that everybody here knows. The top slide is a meta-analysis of ACE inhibitors in heart failure, and you see that there is about a 25% reduction. The slide on your bottom right is a beta blocker, 25% reduction in mortality. And then the spironolactone, the mineralocorticoid receptor antagonist, also reduction. So these are accomplishments. I don't want to say anything that these are very important advances in heart failure, because I see the problems as heart failure with preserved ejection fraction, acute heart failure. Now there's still a ways to go, because if you look at the patients who receive these therapies, they still, plenty of them died. I mean, they're better than placebo, but there's still a lot of deaths. There still is a way to go. Now, we come to Professor Adolfo de Bold. And he is a professor of pathology. He was born in Argentina, but went to Canada for his training. He's a PhD in pathology. And for many years, he was at Queen's University, Hamilton, Ontario, and now he is a distinguished professor at the Ottawa Heart Institute. Adolphe de Bold made one of the most important contributions to biology and medicine in the 20th century. And he did it with a very simple paper, a paper of 3 pages, and you see this is a small journal, and you see came from a typewriter, didn't come from a printing press. A rapid and potent natriuretic response to intravenous injections of atrial myocardial extract in rats. So what does this mean? I told you he was a pathologist, and he noticed in studying the atria of many species that there were granules in the atria. And he was a smart enough guy to say, what are these granules doing here? He looked at them with electron microscopy, and he saw things that looked like substances, that these granules are there for a reason. So he carried out a couple of very simple but brilliant experiments. He took one group of rats and deprived them of sodium and water, and he saw the granules change. And then he took another group of rats and he gave them an excess of sodium water, and the granules disappeared. Well, so he said, there must be something that affects sodium and water balance. So he prepared a crude extract of the atrium and infused it into other rats, and he got a very profound sodium and water excretion. And that, of course, was the discovery of the atrial natriuretic peptide. And he basically discovered a new physiologic system. Now, people make discoveries right and left, but how many times have you heard of a person describing a new system? William Harvey described a new system also. It's called the circulation. And he described the natriuretic peptide system. And how does that fit into heart failure? Well, it hits into heart failure relatively simply. In heart failure, there is distension of the atrium. Distension of the atrium, the granules release the increased tension in the atrial wall. The granules release a substance that he called atrial natriuretic factor. We now call it ANP, atrial natriuretic peptide. And then this produces vasodilatation, diuresis, and natriuresis. But what you're seeing here is, look, I drew a thick arrow. I drew an arrow that began and then it becomes very thin. Now, why is that? It is because we have an enzyme called a neutral endopeptidase discovered by a biochemist in Sheffield, England, also shortened as NEP, which digests the ANP. So, if I were to give an adult human a bolus injection of ANP, it has a half-life of only 2 or 3 minutes. Therefore, that's why that arrow down here is so thin. You don't get much vasodilation, you don't get much diuresis, you don't get much natriuresis. So once that was understood, the drug companies came along and developed an inhibitor of that enzyme, that broke that enzyme, called neprilysin endopeptidase inhibitor. That's why you call it NEPI for short. So when you have NEPI on board, you see it blocks this, and the release of ANP now can produce all of this. So now we have a pharmacologic way of taking advantage of the system that that was described. And of course you saw, and you're all acquainted with the slide, and what this drug, which has unfortunately too many names, the name that Novartis gave it at first was LCZ. It's also, as you heard from the last speaker, an ARNI. What does ARNI mean? Angiotensin receptor neprilysin inhibitor. The trade name is Entresto, and it is also called by scientists sacubitril valsartan. So you got 4 names interchangeable. I think this drug is an important advance. I think you see very few trials that have a p-value that has 6 zeros. So there is the Data Safety Monitoring Committee stopped the trial because it for overwhelming efficacy. And since this trial was published, as you heard from the previous speaker, there's been a lot of confirmation of this. And this drug is making its way. It's been approved all over the world, certainly in Italy as well. And the guidelines now recommend it. So I would say that this is now part of the present. Another part of the present for the treatment of heart failure is the left ventricular assist devices. And the marvelous thing about these devices is they're getting smaller. It's sort of unbelievable that you can get about 5 liters per minute flow from something that fits easily into the palm of the hand. There are several of these. This is the smallest one that is commercially available, and they're safer. This is how they work. I think you all know this. One of the concerns that people have expressed in terms of going forward is this drive line. You see, the energy comes from these batteries, and this is a controller, and you see the line that penetrates here. Well, to have patients on this permanently, these lines become infected. They do become infected after about a year and a half, because these were not built to be there for 10 or 20 years. So I think engineers are working very hard to remove to have a battery pack that's worn as a vest, so that there doesn't have to be a line through the skin. Also, this line wears out the skin, and as I said, it becomes infectious. Now, this is the status of the. We have an agency in the United States that's called Intermax, and in Europe, you are also developing an agency called Euromax, and I think they're going to come together. And so what they show are 15,000 patients that have been treated with these continuous flow devices. Now, the story is not perfect. I think these devices were first set up as bridge to transplantation. Patient is in severe heart failure. You can't find a donor. You put him on this device and you hope you can come up with a donor. You take the device out after 2-3 months, patient gets transplanted. Sometimes a heart couldn't be found. And they say, okay, you just keep on. And so you have then bridge to destination. And at the present time, there are more patients in whom the devices are implanted as a bridge to destination. That is, the destination is to stay on the device. Overall, 15,000 patients, and if you look at this curve, you see that after 4 years, there has been a 50% mortality. Well, these are patients who had a very bad prognosis. 50% mortality is high, it's 12% a year. However, these patients would all have been dead in less than a year. So it represents an advance, but not a final solution. So the future. Future, I believe that cell therapy is going to play a very important role. Now, I think that you know that cell therapy, there are many different cells that can be used and that have been used in different experiments. And now we know that the first cells that were used were myoblasts, skeletal muscle cells, and they didn't work. That's why there's an X there. They caused arrhythmias, and they didn't integrate with the myocytes. I'm circling mesenchymal stem cells that can be extracted from the bone marrow. And the reason I like them is because they are not immunogenic. That means that you can take these cells from a donor, process them, multiply them outside, and put them in a package so that they are off-the-shelf products. And that's going to be the future of cell therapy. Not to take somebody's own cells and to do things with them. Now this is, I think, when industry is going to get into it in a big way. So mesenchymal stem cells. What can you do? Here's some a work with bone marrow stem cells from a group in Slovenia, not very far from here. I think this is the longest term study that I know of with cell therapy. Patients with dilated cardiomyopathy showing a marked improvement in survival. Now, I have to say this is exceptional. Here is a meta-analysis that has looked at also bone marrow stem cells. This meta-analysis comes from a group of statisticians at Oxford, and they have looked only at data in which the long-term follow-up has exceeded 12 months. And you see a reduction in mortality and an improvement in ejection fraction. And I am very impressed with this. Now here's a very interesting paper. It's a very preliminary paper published 2 years ago in Circulation, in which these mesenchymal cells were placed into the heart at the same time as a left ventricular assist device. So this is combination therapy. You can't think of two things that are more different. Cell therapy and LVAD. So mesenchymal precursor cells as adjunct therapy in recipients of contemporary left ventricular assist device. Small trial, not many patients. The conclusion was successful temporary left ventricular assist device weaning. So they were able to take the patients off the LVAD. Was achieved in 50% of the patients who received mesenchymal precursor cells and 20% of the control patients at 90 days. In this preliminary trial, I have to underline preliminary, administration of mesenchymal cells appeared to be safe, and there was a potential signal of efficacy. So I see this very much in the future. And then, of course, we have the capacity now to produce all sorts of cells, pluripotent stem cells from mouse embryonic culture. This came from a Japanese group, and Dr. Yamanaka won the Nobel Prize for that 3 years later. The reprogramming adult cells to embryonic-like pluripotent cells. So this means you could take a cell from your skin and convert it into a cardiomyocyte. Well, it's quite interesting that there has been a change in thinking about cell therapy, which is that it's not so much that the cells that you inject that are transdifferentiating into cardiomyocytes. It looks as if the cells do something which is called a paracrine action. And they release growth factors, cytokines, chemokines, and that these activate endogenous progenitors. So you're injecting cells and they release substances that activate internal progenitors. They inhibit apoptosis, they cause blood vessel formation, and they attenuate left ventricular remodeling, improve cardiac function. So this is the theory, that it's not that the injected cells transdifferentiate. You're not producing more cardiomyocytes. And enter now, and I'm coming close to the end of the lecture, the roles of exosomes in cardiac protection. So what are exosomes? Exosomes are extracellular vesicles, which are key mediators of intercellular communication. And Dr. Marban and groups in Lugano have been studying the roles of exosomes in cardiac protection. And the idea is that these exosomes are released by the cells that you have implanted. And those cells die, but the exosomes are the business part. And this is a wonderful diagram by Sylvester and Professor Menashe from France. And he talks about the evolution of stem cells. And at the bottom he shows the evolution of primates into humans. And at the top he shows all the adult stem cells, beginning with his own myoblasts. No. Okay, and as you can see on top, you go from myoblasts to cardiac stem cells to induced pluripotent cells, and down here, right at the bottom, are these paracrine factors. These are the exosomes, and the work now is devoted to analyzing these exosomes. They're very small. You need an electron microscope to see them. They're 15 nanometers. So what is now believed, and I'm talking about the last 12 months, is that the natural evolution of stem cell theory for cardiac regeneration may end with the development of cell-free strategies, exosomes, with multiple cellular targets, including cardiomyocytes. So this is now cell therapy without cells. Okay, so here's my last slide. So what can I say about the current management of heart failure? There have been great accomplishments in the treatment of heart failure with reduced ejection fraction. And importantly, LCZ 696 has produced improvements in survival. But there's a long way to go. Heart failure with preserved ejection fraction and acute decompensated heart failure, you put these two together, it's about 2/3 of the heart failure population, remain very difficult problems. Now, there are great opportunities for further advances, and these will involve drugs, devices, cell, and maybe gene-based therapy. I didn't have time to go into genes. But it's unlikely that we're going to come up with a magic bullet or a single silver bullet. And I think that going forward, that combination therapy for heart failure is much more likely. I think we're going to need continued cooperation between industry and academia and collaboration with basic scientists, engineers, and clinical investigators. So thank you for your attention. Thank you for allowing me to give the first Attilio Masri lecture.